axial skeleton, we had covered 80 bones, and so we have 126 bones remaining for us to learn about the appendicular skeleton, and most of which are actually found within our hands and within our feet. The bones of the appendicular skeleton include that of the upper and lower limbs, and the girdles of bones that hold and attach the upper and lower limbs of the axial skeleton. The pectoral girdle consists of bones that hold the upper limbs in place, and then the pelvic girdle consists of bones that help hold the lower limbs in place. We have a left and right pectoral girdle that articulates with the trunk and supports each of the one upper limbs. It also serves as an attachment site for many muscles to help move the upper limb. The pectoral girdle consists of two bones, the clavicle, which is the collarbone, and the scapula, which is our shoulder blade. The clavicle is an S-shaped bone that extends between the manubrium of the sternum and the acromion of the scapula. It's the only direct connection between the pectoral girdle and the axial skeleton. The sternal end, or medial end, of the clavicle is roughly pyramidal in shape and articulates with the manubrium of the sternum, which this forms the sternoclavicular joint. The acromial end, or the lateral end of the clavicle, is broad and flattened. The acromial end articulates with the acromion of the scapula, forming the acromial-clavicular joint. The scapula is a broad, flat, triangular bone that forms the shoulder blade. The spine of the scapula is a ridge of bone on the posterior aspect of the scapula, and this is what you can palpate underneath your skin. The spine is continuous with a larger posterior process called the acromion, which forms the bony tip of the shoulder. The acromion articulates with the acromial end of the clavicle. The coracoid process is a smaller, more anterior projection of the scapula. And then finally, the glenoid cavity, or glenoid fossa, is what articulates with the humerus, which is the bone of the arm. The upper limb of our appendages is separated into two components. The arm, which consists of our proximal end of our appendage, and the forearm, which is our distal portion of our appendage. The humerus is the longest and largest upper limb bone found within our arm. At its proximal end, we find the head that articulates with the glenoid cavity of the scapula. Adjacent to the head are the two tubercles. The prominent greater tubercle is positioned more laterally and helps to form the rounded contour of the shoulder. The lesser tubercle is smaller, and it's found more anteriorly and medially. Between the two tubercles, we find the intertubercular groove, or the intertubercular sulcus, which is just a depression that contains the tendon of the long head of the biceps brachii muscle. Between the two tubercles and the head of the humerus is the anatomical neck, which is an almost indistinct groove that marks the location of the former epiphyseal plate. The surgical neck of the humerus is a narrowing of the bone immediately distal to the tubercles at the transition from the head to the shaft. And this is typically the surgical neck because this is a common fracture site. The shaft of the humerus has a roughened area where we find the deltoid tuberosity, which extends along its lateral surface for about half the length of the humerus. Here we find the deltoid muscle of the shoulder attaches to this roughened surface. The medial and lateral epicondyles are going to be the bony side projections on the distal humerus that provide surfaces for muscle attachment. And so you can feel this on yourselves, which are going to be the distal portions in the bumps that you feel at the medial and lateral sides, which are the epicondyles. At the distal end of the humerus There's also two smooth curved surfaces for articulation with the bones of the forearm. The capitulum is rounded and it's located laterally, and that articulates with the head of the radius of the forearm. The trochlea is more of a pulley shape, and it's located medially, and it articulates with the trochlear notch of the ulna from the forearm. And finally, on the posterior side of the humerus, we find a large depression, which is the olecranon fossa, which accommodates the olecranon of the ulna. Within the forearm, we have the ulna and the radius. So we'll begin with the ulna, where this articulates with the humerus of the arm and the radius of the forearm. It forms the elbow joint and the radial ulnar joints. Also, we find the interosseous membrane, which is composed of dense, regular connective tissue that helps keep the radius and ulna in a fixed distance apart from one another and provides a pivot for rotation of the arm. In the anatomical position, we find the ulna to be medial, and so this is going to be the side of our pinky finger. The ulna is longer, and again, it is the medially placed bone of the forearm when looking at the anatomical position. We have a prominent projection that is on the posterior side of the bone, and this is the olecranon process. And the olecranon process articulates with the olecranon fossa of the humerus in the arm, and this forms the posterior bump of your elbow that you can feel. There is a curved radial notch that is found medially, and this accommodates for the head of the radius to articulate and also to help form the proximal radial ulnar joint. At the distal end of the ulna, we find the shaft narrows and terminates into a knob-like head and has a posterior medial styloid process. The styloid process of the ulna is going to be on the medial side, again when in the anatomical position, and it's the little bump that you feel on your wrist. The radius is the lateral bone of the forearm when looking at the anatomical position, and it helps to form the wrist joint and the radial ulnar joint. However, minimal participation occurs with the elbow joint itself. The proximal end of the radius has a disc-shaped head that articulates with the capitulum of the humerus. The radial tuberosity is an attachment site for the biceps brachii. The styloid process, we find this to be at the distal end, and it tends to be wider than the styloid process of the ulna. And so this is what you can also feel on yourselves, and it is going to be your wrist bump on your thumb side. And so again, that will be laterally. On the distal medial surface of the radius, we find the ulnar notch, where the medial surface of the radius articulates with the distal end of the ulna. The bones that form the wrist and the hand are the carpals, metacarpals, and the phalanges. Beginning with the carpals, these are small, short bones that form the wrist. They are arranged roughly in two rows, a proximal row and a distal row. And each row has 4 bones each. And the small bones allow for multiple movements possible at the wrist. So beginning laterally to medially, in the proximal row, we have the scaphoid, which has a boat-like appearance, the lunate, which has a moon appearance, the triquetrum, which has 3 corners to it, and the pisiform, which looks like a P. The distal row of carpals, from laterally to medially, are the trapezium, which has the appearance of a table, the trapezoid, the capitate, having the appearance of a head, and the hamate having the appearance of a hook. And so one way to help remember this is Sally left the party to take Kathy home. And so going from proximal and starting laterally to medially, and doing the same then for the distal, proximal to medial, or lateral to medial. And so here's just another image of the bones within the wrist. The metacarpals are going to be the bones in the palm of the hand, and we have 5 metacarpal bones that articulate with the distal carpal bones and support the palm. Roman numerals 1 through 5 denote the metacarpal bones, with metacarpal 1 being at the base of the thumb and metacarpal 5 being at the base of the little or pinky finger. The bones of the digits are the phalanges. There are 3 phalanges in each of the 2nd through 5th fingers and only 2 phalanges in the thumb. Our thumb is also known as our pollex, and thus we have a total of 14 phalanges in each hand. The proximal phalanx articulates with the head of the metacarpal, while the distal phalanx is the bone in the very tip of the finger. The middle phalanx of each finger lies between the proximal and distal phalanges. However, there is no middle phalanx within the thumb. The os coxae is commonly referred to as the hip bone, where the os coxae is actually the formation of 3 separate bones, the ilium, ischium, and the pubis. Our os coxae fuses when we are between 13 and 15 years of age, and this is what articulates posteriorly with an articular surface of the sacrum at the sacroiliac joint. Now, the pelvis is not the same thing as the os coxae. The pelvis is actually the 4 bones of the sacrum, the coccyx, the left and the right os coxae. Our pelvic girdle refers to only the left and the right os coxae. Again, the pelvic girdle is referred to as the left and the right os coxae. The 3 parts of each individual os coxae are the ilium, the ischium, and the pubis. All 3, when they fuse together, form the acetabulum, which is going to be where the femur articulates with this deep curved depression on the lateral surface of the os coxae. And so again, all 3 bones of the os coxae contribute to a portion of the acetabulum. The obturator foramen, however, is going to be a large hole that is in the os coxae found within the pubis and the ischium. And so this large foramen allows for lots of nerves and blood vessels to travel to the lower limbs. The ilium is the largest of the 3 coxal bones, and it forms the superior region of the os coxae, and it adds the largest portion to the acetabular surface. The superiormost ridge of the ilium is the iliac crest, which you can palpate on yourselves. On the posterior superior edges of your hips, the ridge of the bone that you feel on each side is the iliac crest of the ilium. The iliac crest arises anteriorly from a projection called the anterior superior iliac spine, and also there is an inferior projection that we find and term the posterior inferior iliac spine. This posterior inferior iliac spine is adjacent to a prominent greater sciatic notch through which we find the sciatic nerve traveling to the lower limbs. The ilium fuses with the ischium near the superior and posterior margins of the acetabulum. The ischium accounts for the posterior 2/5 of the acetabular surface. Posterior to the acetabulum, we find the prominent triangular ischial spines that project medially. The lesser sciatic notch is a semicircular depression inferior to the ischial spine. The posterior lateral border of the ischium is a roughened projection called the ischial tuberosity. And oftentimes we call our ischial tuberosities our sit bones because they support the weight of the body when seated. The pubis fuses with the ilium and the ischium at the acetabulum. In the unison of the two pubis bones, we find the pubic symphysis, which is fibrocartilage that we find in between the two. And so this is extremely important for women who undergo childbirthing because this allows for minimal movement and expansion of the pelvis for the birth of the child. So the pelvis is the #1 way that medical examiners and anthropologists use to determine the sex of a human. And so some differences that we find is that the general appearance of a female pelvis tends to be less massive than that of a male pelvis. The general width of a female pelvis has wider hips that are more flared, whereas for the male pelvis, the hips are narrower and more vertically oriented that are less flared. The acetabulum within the female pelvis is smaller compared to males. The greater sciatic notch tends to be wider and shallower than in males, which males have a narrow and a U-shaped, deep, greater sciatic notch. The ilium tends to be shallower in females, whereas it's deeper within males. The obturator foramen tends to be also smaller and triangular among females, whereas in males, the obturator foramen tends to be more oval-shaped. The subpubic angle, which is the angle formed when the left and the right pubic bones are aligned at the pubic symphyses, tends to be broader, more convex, and usually greater than 100 degrees among females, whereas the subpubic angle in males tends to be narrow, more of a V shape, and less than 90 degrees. And this is usually the #1 aspect that medical examiners and anthropologists are looking for at that subpubic angle. The body of the pubis in females tends to be longer and more rectangular as compared to males, where the body of the pubis tends to be shorter and triangular. The sacrum in females is shorter and wider, and also the coccyx tends to have a posterior tilt, whereas in males it tends to have more of a vertical tilt. And again, that has a lot to do with childbirthing. Also, the tilt of the pelvis in females tends to have an anterior tilt, whereas in males it tends to have a relatively vertical tilt to it. And then finally, the ischial spine within the female pelvis rarely projects into the pelvic outlet, again allowing for the head of an infant to pass through the birth canal, whereas the ischial spines of a male pelvis tends to be rotated inwards towards the pelvic outlet. The lower limb is comprised of the thigh, which is going to be at the proximal end, and then the leg, which are going to be our tibia and fibula, which are going to be found distally. The femur comprises the thigh, and the femur is the longest bone in the body, as well as the strongest and heaviest bone that we have. We have a head that is nearly spherical, and this articulates with the pelvis at the acetabulum. The head of the femur connects to the acetabulum at a depression in the head of the femur called the fovea, where we find just a tiny ligament that is responsible for that. The fovea is also known as the fovea capitis as well. Distal to the head, we find an elongated constricted neck that joins the shaft of the femur at an angle. And so this allows for medial angling of the femur that brings the knees closer to the midline. We have two massive, rough processes that originate near the proximal end of the femur and serve as insertion sites for our hip muscles. The greater trochanter projects laterally from the junction of the neck and shaft, and the lesser trochanter is located on the femur's posterior medial surface. The gluteal tuberosity marks the attachment of the gluteus maximus muscle and is found on the posterior side of the femur. When the gluteal tuberosity merges along with the pectineal line, we find the linea aspera on the posterior side. And this is a prominent feature that is found on the shaft of the posterior side of the femur that has this elevated midline ridge. And this is important because it is the attachment site for many thigh muscles. On the distal inferior surface of the femur, we find two smooth, oval articulating surfaces, which are the medial and lateral condyles. And superior to each condyle are projections called the medial and lateral epicondyles. The patella is a large, roughly triangular sesamoid bone that's located within the tendon of the quadriceps femoris muscle. The patella is also known as our kneecap, and it allows the tendon of the quadriceps femoris to glide smoothly, and it protects the knee joint. The leg is comprised of the tibia and fibula, and so we'll begin with the tibia, where the tibia is parallel to the fibula and is a thick and strong compared to the non-weight-bearing fibula that is slender. The two bones are connected by an interosseous membrane, just like the radius and the ulna, that is composed of dense regular connective tissue. And this helps to stabilize the relative position of the tibia and the fibula and provides pivot of minimal rotation for these bones. The tibia articulates with the femur, the fibula, and the ankle bones, and also forms the knee, the ankle, and the tibio-fibular joint that is held stable as well by the interosseous membrane. The tibia is medial to the fibula when looking at the anatomical position. And of the two, it is the only weight-bearing bone within the leg. Again, the tibia is medial and is the only weight-bearing bone of the leg. It has a broad superior head that has two relatively flat surfaces, the medial and lateral condyles that articulate with the medial and lateral condyles of the femur. The rough anterior surface of the tibia near the medial and lateral condyles has the tibial tuberosity, and this is the attachment site for the patellar ligament. The anterior crest, or anterior border, is a ridge that extends distally along the anterior tibial surface from the tibial tuberosity, and is commonly referred to as our shin. The tibia narrows distally, but at its medial border it forms a large, prominent process called the medial malleolus, which you can find this on yourselves if you place your hand on the medial side of your ankle. And this is the ankle bump that you feel, which is the medial malleolus. The fibula is also a bone of the leg, and it is lateral to the tibia in the anatomical position. It doesn't participate in the knee joint, and mostly it's there to help stabilize the ankle joint, even though it is a non-weight-bearing bone. The fibula is the long, thin lateral bone, and it has expanded proximal and distal ends. The important feature of the fibula is that it is the origin of several muscles within the leg. Along the lateral edge of the tibia, the fibula articulates with the surface of the tibia. And so the rounded, knob-like head of the fibula is slightly inferior and posterior to the lateral condyle of the tibia when they articulate together. The fibula also has a lateral malleolus that extends laterally to the ankle joint, where it provides lateral stability for the ankle. And so this is what you can feel on the lateral sides of yourselves, and that is your medial malleolus, where is the bump that you feel. The bones that form the ankle and the foot are the tarsals, metatarsals, and phalanges. There are 7 tarsal bones that we find in the ankle, and they help the ankle bear the body's weight. The largest tarsal bone is the calcaneus, which forms the heel. Its posterior end is a rough knob-like projection and is the attachment point of the calcaneal or Achilles tendon for such muscles such as the gastrocnemius. Also, the posterior-most projection is termed the tuber calcanei, or just meaning heel of the calcaneus bone. The superior-most and second largest tarsal bone is the talus, and the talus, the superior aspect, articulates with the articular surface of the tibia, and the navicular bone, which has the shape of a ship, is found on the medial side of the ankle. So together, these 3 bones, the talus, calcaneus, and navicular bones, are considered the proximal rows of the tarsal bones. The distal rows are composed of 4 tarsal bones, and they are formed by the 3 cuneiform bones and the cuboid bone. The cuneiform bones are wedge-shaped bones that articulate in our position anterior to the navicular bone. They are named according to their position. We have a medial cuneiform, intermediate cuneiform, and lateral cuneiform. And these bones articulate proximally with the anterior surface of the navicular bone. Lastly, the cuboid bone articulates at its medial surface with the lateral cuneiform and the calcaneus. The distal surfaces of the cuboid bone and the 3 cuneiform bones articulate with the metatarsal bones of the foot. The metatarsals and the phalanges comprise the rest of the foot. The metatarsals are 5 long bones similar in arrangement and name as to the metacarpal bones of the hand. They form the sole of the foot and are identified with Roman numerals 1 through 5, proceeding medially to laterally across the sole of the foot. Metatarsals 1 through 3 articulate with the 3 cuneiform bones, while metatarsal 4 and metatarsal 5 articulate with the cuboid bone. Distally, each metatarsal bone articulates with a proximal phalanx. The bones of the toes are called the phalanges, and the toes contain 14 phalanges, just like the phalanges within our hands. The great toe is the hallux, and it has only 2 phalanges, a proximal and a distal, whereas the other 4 toes have 3 phalanges, a proximal, a middle, and a distal.